Assalamualaikum, I am Dr. MOMINA Malik, and today the topic of our presentation is presbyopia. By the end of this presentation, the audience will be able to describe presbyopia, accommodation, the amplitude of accommodation, calculating the add power for near correction, as well as bifocal lenses and day types. Okay, so for starting, if anyone can tell what is presbyopia. Good. So, presbyopia is the physiological insufficiency of accommodation associated with the aging of the eye that results in progressively worsening ability to focus clearly on near objects. So, the thing to notice is that it is not a pathological disease, it is a physiological phenomena occurring with the aging of the eyeball, and there is insufficiency of the accommodation by which the person cannot focus on the near objects clearly. So, how will the patient present to us? He can present with difficulty reading fine print, eye strain when reading for long periods, blurring of near objects, and temporarily blurred vision when changing the viewing distance. So, if we look at this diagram, first, this is a normal eye of a young patient in which the accommodation is intact. While focusing on the near target, you can see that the ciliary body it contracts, which causes the relaxation of the suspensory ligaments, which allow the lens, the elasticity of the lens capsule, allowing it to so that the shape of the lens it becomes more globular. As a result, the refractive power of the eye increases, and the object it is focused onto the retina. However, in presbyopic patients, because the accommodation is insufficient, there is less elasticity of the capsule, and there is resistance to the change of the lens. Therefore, the image of the near object it is focused behind the retina. So, in order for that image to be focused in front of the retina, we have to provide some correction in the form of convex lenses, which will increase the refractive power of the eye, and the image will again be formed onto the retina. Okay, so what is accommodation? It is the ability of the eye to change its dioptric power in order to maintain a clear image or focus the object as its distance changes. Accommodation involves a triad of three things: meiosis, convergence, and the thickening of the lens shape. If we look at this diagram, it is a comparison between an unaccommodated and an accommodated eye. In an unaccommodated eye, the pupil is dilated as compared, and there is tension in the suspensory ligaments, due to which the lens maintains a less globular shape, as in focusing for the far objects. However, in near objects, the pupil it has undergone meiosis due to the contraction of the ciliary muscle, and there is relaxation of the suspensory ligaments, which have allowed the lens to become more globular. So, what is the age of onset? It usually is observed after 40 years of age. However, it will depend upon the pre-existent refractive error. In hypermetropes, the presbyopia will be achieved early, while it will be delayed in myopes. And the depth of the focus, which depends on the pupillary size and the patient's visual tasks. Those who indulge in greater use of near vision, such as stitching and sewing, or they have greater use of IT and screen time, they will observe that the change in near vision will occur earlier as compared to those who do not use near vision much in their daily routine lives. So here we have the average accommodative amplitudes for different ages. We can see that by the age of 8 years, the accommodative amplitude is about 14 diopters, and it will decrease 1 diopter for each 4 years. And so that by the age of 40, the accommodative amplitude is 6 diopters. And after 40, it decreases more rapidly. From age 48 on, again, there is a decrease of 0.5 diopters for every 4 years. So, for comfortable near visions, half of the available accommodation it must be kept in reserve, and we'll provide the correction, keeping in view that half of the accommodative amplitude will be used by the patient, and the rest will be provided by the spectacle correction or the contact lenses. So what is accommodative insufficiency? It is the premature loss of accommodative amplitude, and it may be due to a current or past debilitating illness or the use of medication such as parasympatholytics. Permanent accommodative insufficiency, it may be associated with neurogenic disorders, and the most common cause of premature presbyopia is latent hypermetropia, because the accommodative reserve would be used by the patient in order to correct the hypermetropia. What is accommodative excess? It is caused by ciliary body spasm, and the symptoms include headache, brow ache, blurring of distance vision, and abnormally close near point. And it may be due to uncorrected refractive errors, for example, hypermetropia or astigmatism, and it may be due to a local eye disease, iridocyclitis, which will cause spasm of the ciliary muscle, and all the three processes of accommodation, they will be heightened. Then we have the accommodative convergence to the accommodation ratio. It is expressed as the prism diopters of deviation per diopter of accommodation, and the normal value for this is 3:1 to 5:1. Uh, as we have discussed previously, in hypermetropes, the presbyopia will be developed early and they will require higher correction, in addition to the correction for their refractive error and then for the near correction as well. Whereas in myopes, they will develop presbyopia relatively late and they will require lower near correction. So how will we calculate the presbyopic correction for a patient? The amount of presbyopic correction for a patient is calculated using the accurate baseline refraction, as we have discussed the differences between myopes and hypermetropes, the amplitude of accommodation, as well as the desired working distance depending on the patient's occupational activities. So the baseline refraction we have discussed in the previous presentations. Now we'll see how can we calculate the amplitude of accommodation. So the following tests can be used to determine, there are three tests: the near point of accommodation with accurate distance refraction correction in place. The patient distance correction is applied, whatever it is, myope, hypermetrope. After the corrected refraction, the near point of the patient is assessed by asking him to fixate on a target and moving the target closer to the eye. And when that object will become blur for the patient, that will be the near point of accommodation. We can calculate it using the accommodative rule. We have the Prince rule and the RAF ruler. The use of plus and minus spheres at near distance until the fixation target blurs. We'll discuss all of these ahead. Similarly, as described, the near point of accommodation, we'll simply ask the patient to fixate on a target and move the target closer to the eye of the patient. The point at which the target will become blurred for the patient will be the near point of accommodation. Okay, so it can also be measured using the Prince rule or the RAF rule, the Royal Air Force rule. It can be used to measure the near point of accommodation as well as the near point of convergence. And the amplitude is determined by subtracting the power for the far point as well as the from the near point. So here we can see there are different displays. This vertical line, this is used to determine for the near point of convergence, and the rest of these, any of these can be used to determine the near point of accommodation. We have this screen which can be changed. Any of these four can be used. We have a meter rod in which there are calibrations in centimeter, and this box can be moved onto this meter rod. And this is the handle from which the examiner will be holding it, and this area is known as the wing, and they are placed onto below the eyes of the patient, and the patient is asked to focus on depending on the type of screen we are used, and we can calculate the near point of accommodation as well as convergence with this. Okay, so the third method was measurement by spheres. The minus and plus lenses, they are placed in front of the eye of the patient, and the accommodation is simulated or relaxed respectively. So suppose if the patient, he is focusing with a -3 diopter, and also the blurring then occurs with +2.5 diopters. So the accommodative reserve will be 5.5 diopters. The difference between the plus and the minus spheres for which the near point of accommodation is achieved, that will give us the amplitude of accommodation. Okay, selecting the add power, the amount of accommodation required for patient near vision task is determined, allowing one half to be held in reserve, as we have discussed previously. For example, if a patient has 2 diopter accommodation reserve and the accommodation required is 2.5 diopters, so half of the 2 diopters that will be kept in reserve. So the patients will be using 1 diopter of his own accommodation, and 1.5 diopter will be added to the patient's correction using the spectacle lenses or the contact lenses. So this is important that we have to ensure that half is kept in reserve. If we won't do that, then any slight change in the distance of the near object, it will cause problem and blurring for the patient if no accommodation is kept in reserve. Okay, so usually presbyopia, it is generally treated by using bifocal lenses or trifocal, multifocal, and the contact lenses as well. In today's presentation, we'll only be discussing the bifocal lenses and the various types used. And basically, bifocal lenses, they are used to minimize the inconvenience of patient of using 2 separate glasses for distance vision and the near vision as well. Okay, so generally, bifocal lenses, they the larger part of the lens, or it is usually superiorly the major portion, and it is providing for the distance correction, and the near portion is usually the smaller part, and it is located inferiorly, and it is being provided for the near correction. There are different types of bifocal lenses. We have the split Franklin bifocals, the cemented bifocals, fused bifocals, and the solid or the flat bifocals. The split bifocals, they were the earliest design of bifocal lenses, and as we said that commonly the larger part is the distance. Here they are equal parts for the distance and the near, and the flat bottom of the distance part abuts the flat top of the near lens. This was the earliest design of the bifocal lenses which was used. Then we have the cemented bifocal. This lens design is now almost obsolete. Here we have a lens for distance correction, and the reading edition, it is cemented or attached to the distant lens using ultraviolet cured epoxy resin as an adhesive. And the bifocal is almost very thin, this reading correction which will be applied, and the lens overall appears that it is a single piece of lens, but this design, it is not it has become obsolete now. Then we have the fused bifocals. In this type, the near portion, it is fused to a corresponding depression in the glass of the distant vision, and the near addition, it depends on the refractive index of the glass type. As we can see here for the crown blank, the refractive index is less, and this flint button which is shown, it has a greater refractive index. So basically the near correction is being provided by the higher refractive index for the near segment as compared to the lower for the distant segment. Finally, we have the solid bifocals. Here, the near addition is produced by a different curvature of either the front or back surface of this portion. So, in the previous fused bifocals, we said that the near correction is the difference of the refractive index, whereas in the solid bifocals, the near correction is applied using the different curvature of the lenses used. So that's all for today. This has been prepared from Elkington as well as the American Academy of Ophthalmology. Thank you.
Learning outcomes, and she has nicely described all the learning outcomes. So, full marks for that. Now, the technical word we use is asthenopia because of the strain. Many patients, 50% of patients in our OPD come with the problem that they have eye strain, especially the new generation, young lot who are doing most work on the laptops and on the mobiles. So I tell them that near vision, near work is responsible for that, and this is basically fatigue of your ciliary muscle. I explain them that if you walk 5 kilometers and you have pain in the legs, it is not a disease. Your body does not have that much stamina, so reduce the distance Or if you want to walk 5 kilometers, then be prepared for that pain in the legs. You will have to take Panadol, but better to take a rest after 3 kilometers and then do another 2 kilometers. So basically, the asthenopia is because of the continuous near work. If a patient do the sort of sewing, स्टिचिंग और दाल चुनते हैं, चावल में से पत्थर निकालते हैं. अब person who is reciting the Holy Quran or a person watching movies on the mobile, all these activities put a similar burden on the on the eye, so that there is fatigue, strain, and headache. So to avoid, I tell them after half an hour's near work, then you look at a distance through the window outside and just relax. Then you can do. So I tell them that the fatigue is not a disease. It is a cry of your body that your body says is hands up. Okay, no more near work. This is lack of your stamina. So this is very much physiological. This is not pathological. So change your routine. So this is, see, about 5 out of my 10 private patients, they complain of pain in the eyes, headache, and they are doing excessive near work. So this is one. Now, the ladies who present this problem have special sort of mention. You see, a patient will say that I am 35-year-old, and the patient is having presbyopic symptoms. So what is the cause? One option or one cause may be latent hypermetropia. So I'll see the refraction, and if I still doubt, I will do a cycloplegic refraction. But in most of the cases, the ladies do not tell their exact age. So she will be telling 35 and she will be 45. So, and I will see that on autograph there is no hypermetropia, but still she can't focus here. She is placing her. So I come to know the exact age, the age of the lady. So this is one. But always rule out latent hypermetropia. See, if the symptoms are severe, the best thing is to do a cycloplegic refraction, and that reveals the total amount of hypermetropia. Only refraction will not reveal the exact amount of hypermetropia, because how much has been covered by the ciliary tone, you don't know. Okay, so in this regard, avoid overcorrection. If a patient says that I see well here and I can't see here, it means he or she has been overcorrected. So the patient should be able to focus at 1.5 feet, and the focus should be comfortable even at a distance of 2 feet. So this range, if the patient is comfortable, it means the correction is okay. Now you have shown the Royal Air Force, the instrument RAF rule. How to differentiate between the convergence insufficiency and accommodation insufficiency?
The convergence is measured when there is deviation of the eye at the near point, and accommodation there will be blurring when.
Good. So in RAF rule, when the line comes closer, either the patient will say that there is diplopia, convergence fails, or the eyes will move apart. This means this is the near point of convergence. And near point of accommodation is when the print becomes blurred. So this is fine point between the two. You have described the bifocal lenses, but there is another variety which is called progressive lenses or Varilex. They are a little bit costly. Uh, I think a few years back somebody told me that 7,000 they charge for progressive. So there is no boundary between the far correction and the near correction. The power of the lens gradually increases from the center below. Corridor effect. So it takes 2-3 weeks for the patient to become used to it, but this is another option. Then concentrating on the other options other than the glasses are the best option for the presbyopia, but there are few corneal procedures which we can do in one eye so that the patient is comfortable for near vision. Any procedure which has been done in one is monovian. If we do the cataract surgery, we make the eye perfect for far vision in one eye and for the near vision in another eye. But the other procedure is corneal procedure, thermoplasty. So this is another option being exercised in some way. But you see, the now the emerging market is corneal lens exchange. This is called refractive lens surgery or clear lens extraction. Clear lens extraction is called CLE. Refractive lens surgery is called RLS. So now a patient came to me from England. She rang me up and then she came. My friend has done this multifocal IOL for her in Turkey. So I am from Pakistan, so I have come to Pakistan. So a lot of patients are being operated with multifocal IOLs or the trifocal IOLs in this presbyopic age to correct the presbyopia. See, after 45 years of age, the lens has lost most of its accommodative ability. So it can safely be reduced. I told her that there are a lot of side effects of the operation, and so I did not encourage her. But this is a big market. As we make the cataract surgery more safe, this option will be exercised more. So this is any other comment?
What is jump? Jump, image jump, image jump. Okay. Because of the change in refractive power of the distance in the ear, there is when power is increased in magnification also. तो पेशेंट दूर देखते देखते एकदम से नीचे देखते तो उसको लगता है कि इमेज जो है डिस्प्लेस हुआ है, ठीक है ना, दैट इज इमेज जंप। और उस इमेज जंप को अवॉइड करने के लिए अभी ये जो मल्टीफोकल ट्राईफोकल या वेरी फोकल लेंसेज हैं दे आर बीइंग इंट्रोड्यूस्ड टू अवॉइड दैट जंप, इमेज जंप। अच्छा, इसमें बताइए कि जो बाइफोकल है उसमें हाउ टू, बहुत सारे पेशेंट्स आते हैं कि नहीं इंटॉलरेंस होती है उनको, दे कैन नॉट वेयर इट, तो किस तरह से आप उसको ओवरकम करें? बाइफोकल एडवाइस किया आपने, और बहुत सारी ख्वातीन आती हैं कि वी आर अनएबल यूज इट रेगुलरली, मुश्किल होती है चीज़ें दूर होती। लेकिन बट उन लोगों के लिए तो ठीक है जिन लोगों के लिए दिन में एक दफ़ा कुरान पढ़ना है या कोई ऐसा काम करना है आधे घंटे के लिए, बट अदरवाइज जो बाकी लोग हैं जो ऑल द टाइम दे कैन नॉट चेंज कि कभी एक उतारें दूसरा लगाएं तो उसके लिए फिर ये बाईफोकल और ट्राईफोकल है। उसमें प्रॉब्लम यही आती है कि एकदम पेशेंट को थोड़ा सा लर्न करना पड़ता है। स्पेशली प्रॉब्लम होती है जब वाइल दे आर स्टेयर्स से नीचे आ रहे होते हैं, तो उस वक्त प्रॉब्लम होती है, क्योंकि नियर का जो है वो डिस्टेंस वो आपका देखिए दैट इज अराउंड 33 सेंटीमीटर्स, उससे बियॉन्ड एवरीथिंग इज ब्लर्ड। तो जब वो नीचे सी उसमें से देखते हैं देन दे फाइंड इट डिफिकल्ट, सो आस्क देम टू मूव देयर फेस अहेड अलोंग विद सो दैट उनकी गेज जो है डिस्टेंस के लिए इट इज फ्रॉम द फार डिस्टेंस, जो अपर वाला है उसके लिए। once they learn to live with it तो they get used to it, लेकिन शुरू में थोड़ी सी डिफिकल्टी होती है, तो you have to train them that it will become there will be difficulty but later on if you learn and that will be covered up.
You see, whenever you give presbyopic correction, you ask the patient for which activity you want the near glasses. You see, a few persons are interested in book reading. The retired people, they want the focus to be here. See, and most of the people are interested in near work with a computer or laptop. So they will be placing here. So we want to make the patient comfortable at the distance where he or she wants it. So this is very important. I always tell the patient, you see, there is no glass which can work at 1 foot and at 2 feet. So you have to select, or you want to have an in between correction, so that you can place the near work at 1.5 foot. See, discussing this with the patient is necessary. Otherwise, you correct it for 1 feet, and the patient comes after 1 week that I cannot read the print at the computer, right? So the best thing is that the patient should be told that, okay, we will make you comfortable from this distance to this distance, and you bring your all the work in this range of near work. So in between. But if a person, Ziaulak had three glasses, one for Farvian, one for reading at this distance, and one for when you stand on the podium, you have to place the. So if anybody is interested for this sort of correction, you can offer. Okay, we can have my brother is a pilot. He says that I have to read the checklist of the panel, and the panels are here. So I said, you take one glasses and keep it in the aircraft to see the panel. So if a person is interested, you can offer three glasses, one for near, one for intermediate, and one for distance. So so as I've told you, I have implanted many multifocal intraocular lenses, and the patients are very happy because I tell them that there is no need for near vision glasses. So there are different options now available with different companies. Some companies have different plus add, and let's say Zeiss has a fixed add, but it's a trifocal, and panoptics is another option. Then enhanced depth of EDOF focus. So this is another. Though previously there were only two designs of multifocal lenses. What were these? Diffractive and like back surface to like front surface. Right. So there were two. See, one point more. In accommodation, the how the lens changes in shape. The changes occur at the anterior surface or posterior surface? Anterior. So the posterior surface remains the same. It is the anterior surface which bulges. I have remembered 6 and 10. So the thickness of the lens increases due to bulging forward of anterior capsule, so that it becomes thicker, and the radius of curvature increases or decreases. Increases. Radius of curvature decreases. You see, when a lens become more globular, the radius of curvature becomes smaller. If the radius of curvature is more, the curve will be less. So remember, this is also true for cornea, which happens in keratoconus. The more curved the cornea, the radius of curve decreases. Right? So, any comment? Okay, thank you very much.